I'm going to talk about the ischemia trial, and it's important to know that I was one of 4 PIs of the trial, and my area of direction in the trial had to do with the imaging centers, just as an FYI. And Dr. Berman is going to speak about a lot of the evidence that is pertinent to imaging, and I'm just going to highlight just very briefly some of the preamble evidence as to what the observational evidence has suggested prior to the ischemia trial. Now, before the ischemia trial was published, we saw observational evidence such as this on the left-hand side of the slide, showing that beyond a given amount of ischemia, moderate to severe ischemia encumbering 10% of the myocardium or greater, there was basically halving of coronary disease death in patients who underwent coronary revascularization. Now, it's important, this is a very large study, it was extremely well done analysis, but it is observational. And of course, there can be a lot of differences and nuances between the assignment of patients to revascularization versus medical therapy, et cetera. And also, this was published, and really data was derived from some 20 years ago. Although, and I would have thought prior to more recent publications that this data was perhaps somewhat stuck in time and wasn't relevant to current practices. But there have been several papers, as you can see on the bottom, and on the top right-hand side from Dr. Krishna Patel, who did a fabulous talk earlier on PET ischemia, as well as some data using the new CZT SPECT cameras, showing these same results of a reduction in risk with revascularization, but all from observational findings. Now, the stable ischemic heart disease trials up until somewhere around 2009, Courage and Berry 2D failed to establish any difference in outcome between patients that were given contemporary optimal medical therapy as compared to revascularization. These p-values aren't remotely significant or borderline. And of course, I think Dr. Shaw talked about this very nicely, is that the eligibility criteria were minimal in terms of ischemia, and often the ischemia was very small amounts of ischemia and without what most people, in particular Dr. Berman, Dr. Jane, and others on this call would say is prognostically important. And in some cases, anatomic eligibility allowed for enrollment. So it wasn't the same as you can expect, as we'll talk about just in a moment with the FAME trials. There has been, though, and this is an extremely fundamental and important and patient-centered finding that we've seen throughout the literature, and that is that revascularization, PCI plus medical therapy, is associated with a prompt and durable improvement in angina. As we can see from the Courage trial, and we'll see later on in this presentation, an early and through 3 years improvement in angina. This will be a consistent theme. Even as you talk about the FAME trial, now Dr. Shaw talked about this, and it was stopped early because of this potential hazard, this 3-component endpoint of all-cause death, myocardial infarction, and urgent revascularization. But of all of those 3-component endpoints, urgent revascularization was the lone significant a variable of all of those 3-component endpoints that was significant and which was driving that difference in the medical therapy arm. Now, the trial was stopped early, so it's really important that we see that 5-year outcome data just published a few years ago in New England Journal, showing a maintenance of that benefit with FFR-guided PCI to reduce that primary outcome. But importantly, so it's urgent revascularization. And if we think about this continuum of benefit of revascularization, it focuses solely on symptom relief, whether it be stable angina or, in the case of FAME, that urgent revascularization, those instability or unstable symptoms associated with that. This is the gamut upon which we can see, and we feel very comfortable now with multiple trials showing revascularization is associated with symptom relief. But this is where we come to the Ischemia Trial. And here you can see the design on this. Everybody is well aware of this, so I'm going to go through this rather quickly, but I'm going to highlight areas that I think are important. One is the moderate or severe ischemia was determined by the site. It's interpreted by the core lab. We used a blinded CTA to rule out left main. You certainly would not want to treat somebody conservatively with left main, at least right now with our current evidence, and to rule out non-obstructive disease, because we know ischemia in the setting of non-obstructive disease is real, and you see this often in your patients. The exclusion criteria on the lower left are fundamental to understanding the trial. We excluded left main, any depressed ejection fraction. That's important because Stitch covered that, as well as, I think, notably, patients who had ACS within 2 months, or those that had unacceptable levels of angina. So, and the screen failures, if you go down this slide, you look, the screen failures excluded patients with non-obstructive disease in left main. When the randomization was done before the cath lab, no other trial had done that. You were randomized to an invasive strategy versus a conservative strategy. And there are two components of this which are fundamental to understanding, is that the invasive strategy had to have, the aim was optimal revascularization. We've already heard some discussions about completeness of revascularization. That's going to rear its head in this discussion as well. And the conservative strategy, where cath was reserved solely for OMT or optimal medical therapy failure. So let's look at some of the results. Now, importantly, what you see is a patient population largely with a preserved ejection fraction. This is already going to give you a flare. When I saw these findings before this was published, I said, a patient with moderate to severe ischemia with a preserved EF, it's going to be a lower risk population. That's fundamental to what you're seeing. Although most patients had a history of angina, there were only about 30% of patients that had new onset, or their angina perhaps became more frequent over the past 3 months. And yet on the right, you can see that these are patients with a lot of disease. Roughly 3/4 had multivessel disease. Here you see the qualifying stress test. This is the core lab interpretation. On the top left, you can see the criteria. Dr. Berman, I know, will go into this in more detail. About 2 years into the trial, we added on exercise ECG. The criteria are pretty complex. I think I highlighted in yellow the two relevant criteria. I think importantly that exercise ECG, the ECG criteria, I personally don't think are at the level of risk associated with the other stress imaging modalities. And this is why we added on, you have to have a 70% stenosis in the proximal or midsection of a coronary artery. You could see that on the right, this figure of the nuclear echo and CMR, the number of patients that had moderate to severe, and about 700 patients had insufficient ischemia. There was only one criteria for the ECG, and that's why it's depicted only as severe. But let's look at the medical therapy arm, because there's been discussion about statins and other types of medical therapy. And there are two messages that come from this slide. One is you would have to be concerned about pre-treatment, since most patients were on statins, although not on high-intensity statins, and most patients were on aspirin. High amount of patients were on ACEs or ARBs. There were no differences between the invasive and conservative strategies, and you can see you had slight improvements in LDL, systolic blood pressure, patients not smoking, etc. But this is a patient population that has a high degree of adherence to guideline best practices. And so we do have to be concerned about pre-treatment, and the level of improvement into what's called high-level preventive optimization was about 40%. So it doubled, much more strongly adherent, but still a population which had a good degree of treatment already. Now, this slide, I think, is fundamental to thinking about the trial. You can see both for cardiac cath on the left and revascularization on the right. For cardiac cath, you can see that quite early on, there were a few patients, about 1 in 10 patients, that had early event or perhaps OMT failure. Overall, about 30% of the patients in the conservatively treated arm, the medical therapy arm, had OMT failure and crossed over to cardiac catheterization. Now, for the most part, cardiac catheterization was undertaken very promptly. But in the case of revascularization, what we see, interestingly, is only about half the patients underwent revascularization within 6 weeks. Now, certainly, if you think about a patient with moderate to severe ischemia, there's often on the part of the stress imagers this kind of acuity and promptness of care that they would like to see because they're concerned about the risk in the population. So we have to have a little bit more information about that. Why was that taken? Wasn't taken very promptly. Could just be scheduling, but it's important for us to get a deeper dive on that. Now, only about 80% of the invasive group was underwent revascularization. So that 20% included patients, about half of which had insignificant coronary disease, and another group, the other quarter of that group, actually had too extensive disease. So this is kind of interesting to frame the trial. These are strategy trials, so there's a lot of nuances to understanding these more complex strategy trials. You all have seen these, so I'm going to go quickly through this because I think it's important for us to focus. Now, these curves crossed. So it's important to realize that that violates the proportional hazards assumption for that statistical analysis. So there's a lot of ongoing discussion about whether or not you could actually use a Cox model for that. But at 4 years, there was no difference in outcome, but you see this bump at 6 months. And Dr. Schall talked about this. Dr. Pandey alluded to this issue of procedural myocardial infarctions. We're going to talk about this in a moment on the next slide. Importantly, you see an early hazard and a potential late benefit. Now, the early potential harm, I should say, related to revascularization has to be attributed to how much of that is completely revascularization and how much of other arteries were left without being intervened upon. But there's an interesting late benefit, and hopefully the investigators, we have proposed a longer-term follow-up, and I think if these curves continue to separate, it will be wonderful news for this longer-term benefit. This slide perhaps gets overlooked a lot, but I think Dr. Schall and Dr. Pandey talked about this, and I'm going to just highlight very quickly. If you look at cardiovascular death, you don't see that same bump in procedural MI. So obviously this is telling us that these procedural MIs are not fatal, and therefore the clinical significance of that procedural MI has been questioned in many, many other trials, and I think requires more insight into understanding what's going on in the size of these non-fatal myocardial infarctions. The spontaneous MI, you could see these curves start to separate at 1 year. I think this is going to be fundamental to understanding the trial, and Dr. Pandey, I believe, or Dr. Schall, I both mentioned a meta-analysis that was published in Circulation that talked about this non-procedural MI benefit with revascularization, which is really, really important from a patient-centered perspective. There were no heterogeneity of treatment effects, both in terms of the severity of coronary disease, proximal LAD disease, the severity of ischemia. This was surprising to all of us. We certainly need a deeper dive into this. My final couple slides, I just thought I'd share with you, I think, what is the most important, particularly from your patient's perspective, and that is the improvement in angina, whether or not the patient had daily, weekly, or monthly angina. We can see at 3 months a clear separation in the blue line from those patients that were treated with medical therapy alone versus the invasive arm in red. And that difference is clear across all the different patient populations with daily, weekly, or monthly angina. And these differences were not seen in the patients who don't have angina to begin with, but they do persist over 12 and 36 months. But that same no difference in angina is not shown through 36 months. And so I think what you can safely say throughout all the trials, and this is really important, I know we'd like to see more patients surviving and show a benefit with cardiovascular death, but I do believe that this is a really important. Improved angina control with invasive strategies is important. Asymptomatic ischemia, that same benefit doesn't occur, and this is consistent across all of the stable coronary disease trials. So the strengths: very large trial randomization prior to invasive angiography, core lab interpretation for ischemia severity and CTA, similar medical therapy in both arms, a high rate of follow-up. I'm really worried about the inclusion of lower risk patients, which always happens in these larger trials, most with the normal EF, most mildly symptomatic or asymptomatic in the prior month. 14% had insufficient ischemia, and then the exclusion of those with left main stenosis perhaps is receiving some focus. One more slide in my summary slide is to focus in on the results. Prompt invasive strategies don't reduce risk, but they do actually improve angina control, which I think is a strong support for invasive strategies. But I do think there is a strong message for optimizing medical therapy and I think a greater focus on symptom relief as a primary aim of care should ensue with this. I think CTA has shown itself, particularly there's a lot of strong leaders in CT in India, as we've seen on discussions on this slide today, on this talks today. CTA is accurate to detect left main and exclude non-obstructive disease, where Dr. Narula and I are actually developing a grant to actually analyze the atherosclerotic plaque, which I think will be fascinating to see, particularly about the procedural MIs or even the spontaneous MIs. We do need some more data on completeness of revascularization, and I think the longer term follow-up is a must for us to see if these treatment curves continue to separate. So thank you so much for your attention and allowing me to speak with you today. Thank you.